add something? So basically, people are seeing more and more graft dysfunction, and because of the use of marginal livers, and the problem is because there is no global criteria, there's no universal criteria. I mean, Nigel and Srinivas, you mentioned so many criteria, and every center or every country used completely different criteria. So the new studies that are using graft dysfunction as an endpoint, they just find it very difficult to be funded and to be actually to end anywhere, because there's no universal criteria. So this is really a point that people are working on it, but then I'm not sure how much. And the criteria has to be different actually between DCD, DBD, and living donors, because they are completely different grafts.
Yeah, I think you're right. If you look at some of these latest, the L graft and those sorts of things, people are trying to create a way of identifying graft dysfunction that's common for both living donor and deceased donor liver transplantation. But from my point of view, they're so different for that first 5 to 7 days, and the implications of graft dysfunction and the causes are by and large, are very different, that I think it's difficult to come up with a universal system. And I think our focus has to be much more on the prevention, how to avoid it. And obviously in India, the pressure is there isn't a huge amount of cadaveric donation. You're wanting to try and use every liver that's being offered, but on the other hand, you're wanting to avoid the pitfalls of early severe graft dysfunction, graft loss, patient loss. So it's a tightrope. And for me, I think having trials of machine perfusion and allowing experience to develop may help at least in the earlier days of cadaveric transplantation in India. Okay, I think, should we wrap things up? So
yes.
look, I'd like sorry, Raj.
Yes, Prof. And regarding ICU point of view, we would like to ask Dr. Selva. He has seen with machine perfusion livers also normal DBDs and LDLTs in the initial phases, and the difficulties he faced with the machine perfusion and straightforward DBD. Do you want to throw it?
Yeah, thanks for that excellent talk, Prof. So basically, we didn't manage a lot of machine perfusion patients. Only one patient did. But I think, as you were saying lately, the first week was completely different between graft dysfunction in DDLT and ADLT. And the machine perfusion patient behaved more like say like a LDLT patient, behaving more with cholestasis and the secondary sepsis, graft dysfunction types. So the problems with the LDLT EADs is that after day 7, when the bilirubin is creeping up, the most common problem we face is whether this patient is in the spectrum of immunosuppression. Are they hypo? Are they hyper, or are they on the path? Shall we wait or go up on the immunosuppression? So this is the question we had with that patient also. I guess we probably erred on the side of over immunosuppression, and he ended up with fungal sepsis. So this question is, I know whether you have those situations and how do we handle this?
Well, that's a problem. Maybe Abid, would you like to comment on that?
Yeah, and thank you. And I think it's a really difficult scenario, because they are patients who have this elevated bilirubin. The transaminases are elevated, but not in a particular pattern. The liver function tests are not specific. You think they've got this slightly sick septic liver, but you want to exclude rejection. They're difficult to biopsy. They've got the coagulopathy, and unless you have access to transvenous biopsy to make it as safe as possible, they're difficult patients to biopsy. I think our first step would be to treat sepsis, check for viral infection, check for technical complications, get some good quality imaging, run their tacrolimus level between the 6 and 10 where you want it to be. But if things don't settle or think the trajectory is wrong, then we would go forward to biopsy, preferably by the transvenous route, to try and understand exactly what is going on. Certainly would try and avoid pulsing without good evidence that there is rejection. Eosinophilia, there's some evidence to suggest that eosinophils go up 24 hours before your AST starts going up in the context of rejection. I think that can be a nice adjunctive sign, but not to hang your hat on. We've certainly seen rejection without eosinophilia as well, but that can be another marker of rejection.
I just had one more question on the PNF. I know PNF, we understand, is a multi-organ failure with severe lactic acidosis, almost mimicking acute liver failure. So this patient, the case which was presented, had a neurological deficit post-op. So is intracranial hypertension a big concern in the PNF patients, especially after DDLTs? Because LDLTs, we never see any, say, rather significant encephalopathy in the post-ops. So the PNF in DDLTs, do they present with raised ICPs or any concerns in that direction?
In the chronic setting, the neurocognitive dysfunction is often residual encephalopathy and the multiple metabolic insults. So with this patient, although she had an ACLF phenotype, the neurocognitive dysfunction was probably multifactorial, drugs, persistent encephalopathy, etc. There were no signs of raised intracranial pressure. I suppose, Nigel, in the context of transplantation for hyperacute liver failure, if the graft wasn't working, one of the signs would be that the ICP wasn't settling?
Yes, I think in very severe primary non-function, we've seen some patients with neurological complications and cerebral edema. Tends not to be at the time of transplant, but 24, 36 hours after. And I think those are in the very severe cases. Fortunately, it's rare.
And usually the ones transplanted for the acute liver failure rather than chronic liver disease?
I think probably, if I think back, that would be more the most common setting we've seen it in. Yes, yeah. Raj, you're muted, I think.
Yeah, I think Srini can go ahead. Srini, you want to tell time, what of time?
Oh, okay. Thank you. I think it's been a great session. I think I hope it's the beginning of many. And I'd like to thank Professor Heaton for agreeing to be the lead for this series of sessions that we're going to do. I think I'd like to really thank the King's College team, obviously Professor Heaton, Dr. Wael Jessam, Dr. Abdul Sidil, and Dr. Shruti for taking part and joining with the discussion and helping us clear our doubts, actually. I'd like to thank our Gleneagles global team, the entire liver department. It's a big department, but I think most of them have been running around today trying to sort this thing out, because it's been a completely in-house production and without any external help. So I think it's gone very well. I think special thanks to Ms. Moa and Mr. Alok, who did most of the background work. And I think overall, we'll hope to have another session in 3 months' time. I think that's what we're looking at, every quarterly meeting. And I think that's it from me. I hope everybody has a good weekend. And
Prof, you want to say something, Prof?
Well, I'd like to echo those thanks from Srinivas to everyone who's been involved today, and for the global team for getting it all sorted. And it's enjoyable, and I think it's great to contrast the problems from living donor and cadaveric, and to share experiences, because you're always learning. I think we'd like to carry on with the series, and next time round, I think we'd like to look at portal hypertension and before, during, and after liver transplantation. It's management, because I think for me this is really one of the most fascinating areas of transplantation today. It's there in young people, and I think it's a challenge for the whole surgical, anaesthetic, and intensive care team. So with that, I'd like to thank everyone and wish them a great weekend in the rain in Chennai and in the ice and cold in South London. Okay, have a great weekend. Thank you.
Thank you very
care.
much.
Bye bye.
Thank you,
Bye-bye.
Abid, and thank you, Wael.
Thanks.
Pleasure.
Bye.
Bye bye.